Explain it like I'm 5.
So, welcome back to EX5, Explain It Like I'm 5 podcast. Today we have Lilian Caton, pharmacist with Mosaic Life Care in St. Joseph, Missouri, who also happens to be my fiance. So, you may see some extra chemistry if you're watching this video podcast. But I'm excited to have Lily on here because I've managed to spend a lot of time with her, obviously, over the past 2 years and learned a lot about drugs, both illegal and legal, from the vantage point of a pharmacist. So, Lily, thank you very much for coming on.
Thank you for having me.
Tell the listeners and the viewers a little bit about what a pharmacist is. I think there may be some misconception about exactly what you do.
Right. Even my family doesn't really know what I do because every time I tell them I go and talk to patients at the hospital, they are so confused. So basically, to be a pharmacist nowadays, it's a doctorate degree. So I have a doctor of pharmacy degree, although only my grandma and my students call me doctor. Everybody at work just calls me Lily. But basically, we are there to ensure when a doctor writes a prescription for something that it is the appropriate dose for the patient, that it's not going to interact with any other medications, that it's going to be safe for them. And there's a lot of different kinds of pharmacists. So there are pharmacists that you see at like CVS or Walgreens. That's what we call retail pharmacy. And then there is hospital pharmacy, which I do. And so we are actually in the hospital working with the acutely sick patients.
So, what's life in a hospital like?
It can be chaotic, definitely, at times. Summers are usually slower for us. Winters are usually more busy because of flu season and, everybody getting pneumonia, things like that. But I am typically on a patient floor. And so I have anywhere from 12 to 48 patients that I'm in charge of. And I verify all their medication orders, make sure everything's dosed appropriately for them, make sure they're on the right antibiotics for whatever bugs they happen to be growing.
So, are you able to prescribe drugs,
I
or
am
where do you fit in that scenario?
not yet. Eventually, pharmacy would like to move into that arena, and I know they're pushing legislation for that, but currently pharmacists in the state cannot
So
prescribe
the
anything.
flow is I go into a hospital, I'm sick. Let's say it's, I've got something that an antibiotic can take care of. So the doctor is going to prescribe an antibiotic, but it's your job to be the go between to make sure that it's dosed right, that for the patient, any pre existing conditions, that they have the right medication. So you're really like the human computer in between. Would that be a fair assessment?
Right.
Well, that's fantastic.
A lot of
Would,
responsibility.
would you call yourself a legalized or educated drug dealer? I know we hear that a lot. Would you call yourself that?
I would not personally call myself that since I went through the 6 years to become a doctor of pharmacy. But if I had to choose between legal drug dealer and educated drug dealer, I would choose educated drug dealer. But again, I don't prescribe, so I'm just basically the middleman handing out the drug.
Well, let's get into some of the hard details here. Can you explain for us the FDA scheduling, Schedule 1, Schedule 2, what's in those and how that process actually works?
Right. So for a drug to be in a schedule, basically the attorney general is the one who makes the final decision of what schedule a medication is. And you have schedule 1 through 5. So schedule 1 is any medication that they have deemed does not have a medical purpose and it has a high abuse potential. So things like marijuana, peyote, heroin, those are all Schedule 1 medications. And so you cannot go and pick those up from a pharmacy anywhere. Then when you get into the Schedule 2 through 5, they look at your abuse potential for the medication and how harmful it can be. So Schedule 2 is going to be the next highest for abuse potential, both physical and mental dependence. So if you stop taking the medication, you're both going to withdraw physically and mentally from the medication. And those are things like cocaine and methamphetamine, which I think people don't necessarily think those are Schedule 2. But we actually have cocaine in my pharmacy right now because they use those in surgeries. And with methamphetamine,
For the doctor or for the patient?
for the patient.
Okay.
For the methamphetamine, it was actually a prescription medication first. And then people in the streets started making it with other substances. And so that's what we see more nowadays because nobody is actually prescribing actual meth.
Why is marijuana a Schedule 1 when something like cocaine and meth being a Schedule 2? That seems upside down.
Right. But a lot of times for these medications, you have to play ball with going through the FDA process of getting a drug to market. And you have to show that the drug is efficacious, so it has efficacy to it, and that it's safe. And so if you don't take them through the drug trial process, then you'll never have deemed medical purpose because you're not going to be approved by the FDA to have a medical
So
use.
what you're telling me is something like marijuana that's had clearly a high use of abuse, correct?
Right.
A high use of abuse is on a Schedule 1. Uh, a mixture between not having enough research to show the medical benefits. Now, while many of us out there would say, clearly there's medical benefits, there's medical marijuana, I can show you and I can prove to you my experience, your experience means nothing when you have to take a pharmaceutical drug to market and have pharmacists like you learn about and prescribe it. There has to be a consistent result and approach. Is that correct?
Right. And when these drugs go through drug trials, that's where we learn what dose is effective for a patient, what side effects a patient might see. And so that's where we learn a lot from the drug is going through these drug trials. So if you're not taking marijuana through drug trials and we don't know how much THC is in every strain, and it's hard to, you know, have people grow the exact same thing everywhere, then we're never going to be able to use it for medical purposes until we can have something regulated.
So you mentioned earlier, you said efficacy. What's that word and how's that work and defined in the world of pharmacy?
So, efficacy in a drug trial, it depends on what you're looking at. So, let's say they're trying to take a new blood pressure medication to market. Then they want to show that the medication actually lowers your blood pressure how they think it's going to do it and that it's not going to be harmful in the process. So every medication has side effects. It doesn't matter what you ingest, it has a side effect to it. But they want to make sure that it is actually going to work for the patient with not too many side effects.
So, from my understanding, and with these drug trials, I mean, we sometimes hear about them like
Yeah.
they're in early stage drug trials. The goal of the FDA and people doing these drug trials is to ensure that when the mass receives any medication of any sort, that it's incredibly consistent and that there's a lot of known knowledge on it. And there's nothing that's going to be surprisingly come up. Is that correct?
Correct.
Do you think we take for granted the FDA process? Like we just beat them up, but we really should appreciate it more?
I do think so. And there are a lot of drug trials out there. So, as a pharmacist, a huge part of my job is keeping up with all these drug trials and really learning how to look at the drug trials and see if it was a good trial setup. Because sometimes you can finagle trials to make them look better than what they actually are. And so, being able to look through it and see was this trial set up so that you can generalize the information to a lot of patients? Or is it set up in a way where only one specific patient population is that drug going to work in? And you can't say, well, you studied it in this group of patients. I can't give it to this other group of patients because I can't generalize that information. And so that's also a huge part of our job is making sure that what we're seeing in the drug trials, we can actually expand to our patient population.
Let's talk a little bit about meth. So, you are a doctor in St. Joseph, Missouri, which is hugely abundant with people coming in from meth overdoses. Independence, Missouri is often the number one, sometimes called the meth capital of the world. Uh, Tell me a little bit about meth and your experience and why are we seeing so much of this?
Meth is cheap, and people like to do things that are cheap. People also really like to do stimulants just because of the way it makes them feel. So when you stimulate, you're obviously increasing the reaction time of your central nervous system. So you're able to think faster, be more efficient, things like that. Obviously, when you start abusing meth, then you get into the area where that's all you're doing and you aren't being productive in anything else.
And isn't meth, I mean, pretty much Adderall? I mean, methamphetamine is, and Adderall is an amphetamine, right?
Right. So the generic name of Adderall is amphetamine salts. And so methamphetamine is just a methylated derivative. And so basically, when you ingest meth, it turns into amphetamine in your body. And so we have a regulated, and methamphetamine, again, there is a pill that is FDA approved, but the meth you get on the street could have any amount of any substance in it. And so Adderall is kind of a regulated
So
medication.
Adderall is something that's consistent and known and done in labs, in pharmaceutical manufacturing facilities around the world. And meth is made with containers and pots and pans in a broke down home in Independence, right?
Oh, even better, they're now doing shake and bake methods where they do it in a pop bottle driving around in cars.
So they get in a car and they somehow do this in a pop bottle. Wow. Okay. Talk about innovation there. What happens when you OD on meth?
So it depends on how much you take, how fast these symptoms are going to happen. But basically, it's a stimulant. So it's going to increase your blood pressure to a dangerous level a lot of times. It's going to increase your heart rate. You can go into a coma. You can have what's called rhabdomyolysis, and that's basically a muscle breakdown. So your body temperature gets really high when you overdose on meth because your muscles are continuously twitching because they're stimulated by the methamphetamine. And so when you have that muscle breakdown, your kidneys can't process all of that. And so you actually go into kidney failure. And a lot of times you have to have hemodialysis, which is where they filter all the things that your kidneys normally would filter so that you don't die, basically.
So what you're telling me is ODing on meth is something that is like driving your car in first gear and running it to the rev limiter and basically collapsing your body the same way a car can't handle running in the rev limiter all the time.
Correct.
Other than meth, what do you see the most of? What do you see the most abuse or ODing coming into your hospital?
So I do work in the emergency department every once in a while, and I would say probably our next second highest OD that we see is heroin. And in my area, that is just what is coming up big again. Heroin is pretty cheap as well, and you'll see a lot of things that are cheap, people start to use a lot. They are starting to cut it with fentanyl, things like that, and so it's more potent heroin, and so we see a lot more overdoses on that. Um, with methamphetamine, there's no antidote for it, so we can't give you a medication and like the meth gets reversed. So we have to wait for it to take its course and run out of your body. But with heroin, we can give you Narcan, which reverses it. So basically, heroin sits on the opioid receptor, and Narcan kicks that heroin off the opioid receptor, but it doesn't last very long. So then the Narcan goes out of your body, and that heroin goes back onto the opioid receptor. So a lot of times, these patients will have to be on drips until the heroin is completely out of their system.
What's a drip?
So a drip is an IV medication. So it's a continuous infusion of Narcan into your body until the heroin is out of your system.
So is it worse to be ODing? I mean, not that you're promoting either, but is it worse to OD on heroin or OD on meth?
It depends on how quickly EMS services can get to you, because heroin, you can die pretty quickly of respiratory depression. So basically, you stop breathing. But if you have Narcan available to you, you'll live more than likely. But with methamphetamine, you might not die right away, but you could have longer term.
So with something like
effects.
heroin, I could just be dosing myself normally of how I like to take my heroin, and then all of a sudden I just stop breathing. You're not going to know. But with meth, it's something that's almost a silent killer to where you may not show the symptoms, but your body's dying.
Oh, well, you'll show the symptoms, but it won't be as abrupt.
Which drug, recreational or prescribed, would you contend is the most capable of killing someone if they overdose on it?
I would definitely say Tylenol, which
Tylenol, like
Yes.
over-the-counter Tylenol.
like over-the-counter Tylenol.
Okay.
So basically what happens when you overdose on Tylenol is it affects your liver, and your liver can't process all of the Tylenol, and so it stops working. And so a lot of times you get really sick for the first couple days, and that's the acute, so the short-term effects of the Tylenol on the liver. And then day like 4 or 5, you'll start feeling better. And then after that, your liver will completely shut down.
How much Tylenol are we talking about? Are we talking about like 5 pills? Are we talking like a whole bottle? How much are we talking about here?
Well, the recommended daily limit over a 24-hour period is 3.25 grams. So anything over that would be considered an overdose, because an overdose is anything over the recommended dosage.
So it's not like a speed limit sign where it's like recommended speed, right? It's like recommended is actually a scientific term for this, correct?
Correct. So it used to be 4 grams, and then they saw an increase in toxicities. And so they actually decreased it during the time I was in pharmacy school to 3.25 grams.
So 3.25 grams in relation, is that like pill wise? If you go to the store and you get a typical bottle of Tylenol, how much is typically each pill?
So if it's an extended release, which I think is what a lot of people get, it's the 500 milligrams.
Okay. So that's what 3.25 divided by zero point 0.5. So or times two. So you're 6, 7 pills in, right? So you could take 6 pills and it could be potentially dangerous and you could die in a 24-hour period.
You might not die from that much, but anything over that is highly not recommended.
That's a big risk.
A big risk.
Which drug would you tell? Which drug would you tell everybody out there? Just don't try this. You're going to get hooked and there's no turning back.
I'm going to kind of cheat and say the whole class of stimulants. And that's just because they have very addictive properties. So that's things like cocaine, crack cocaine, meth, Adderall. Unless you are prescribed it for a legitimate medical purpose, and for Adderall, that means not getting it from any doctor, getting it from a psychiatrist, because that is within their scope of practice, then I don't think that anybody should try those medications.
And do you feel like that's just because of the feeling, or they're highly addictive or highly destructive? What would be your kind of main classification as to why they shouldn't?
Well, if you have any history of cardiac issues, you definitely shouldn't ever. And cardiac issues are heart problems. Family history of heart problems, those patients need to be monitored very closely on these medications. But also they are very highly addictive and also highly destructive.
Let's talk opiates. It's obviously a very controversial topic. It's something that I think the media has said there's an opiate crisis.
Yeah.
Tell me a little bit about your experience. What's the controversy around them? Give the listeners a general understanding of that.
Right. So I come from the healthcare aspect of it. Yes, I have been a patient. Yes, I have been prescribed opioids when I had my wisdom teeth pulled. I hated them. I didn't even take them. But from the healthcare side of it, it's difficult because, especially back in the 90s, a lot of what the hospitals and doctors were graded on was patient satisfaction scores. And pain was a big patient satisfaction score. That's where anytime you go to the doctor, the hospital, anywhere, they have that pain scale where you see the faces and they want you to rate your pain on a scale of 0 to 10. And I think what we don't explain to patients is a lot of times we can't get your pain to be a 0. And we want to take it to a tolerable level. So instead of being at a 10, let's say you just had like abdominal surgery, so surgery on your stomach, you're going to be in pain. We don't want you to be at a 10, but if your tolerable level is a 4, we want to bring you down to a 4. If it's at a 7, we want to bring you down to a 7. And we want to help manage your pain as best as we can. And there is also a difference between acute pain and chronic pain, and then also pain due to cancer. So those are kind of like 3 different classes of pain. So acutely, you might have to be on stronger meds because something happened. But over time, you shouldn't still be on those meds, because hopefully we'll be able to get a better regimen for you.
For these being opiates, I've heard plenty of people that have had kind of firsthand experiences, and there's a lot of blame to a lot of different people. And, in the scale, you've got pharmaceutical companies producing opiates that are then convincing doctors to prescribe. However, there's something in the system, which you just mentioned, which is, the benchmarks for doctors and pharmacists is what is their pain level. So you're trying to reduce the pain by prescribing more opiates, but not really understanding somebody's personal addiction level, their abilities to become addicted to it. And so is it fair to say that there's a lot of things going on? And is it fair to say that, it's both a patient and a doctor, not necessarily I could say fault, but where do you think the blame is to put in something like this?
I don't think there really is a blame. If there is a blame, I think it's mutual. Um, as healthcare providers, it's hard to try and motivate your patients to do what's right for them and to make sure that they can effectively take care of their own health. But as a patient, you can't rely on a physician to give you a pill and make everything okay. You have to be able to put work in. And so I think if we are going to blame, it's going to be everyone's to
Just how
blame.
big is the opioid crisis?
Yeah. So in 2016, more than 11.5 million Americans reported that they misused opioids. And so that's just who reported that they misused it. And that's also stating that they misused it.
And
So
that's like
it's
4% of the US population.
yeah, and that's not even all the patients that are on opioids. They're just the ones who think that they misuse it. So we have tons of patients that are on opioid medications.
What do you feel like is a legitimate alternative? So let's say there's somebody out here listening to this podcast that has a relative or even themselves that found, they were in for a leg surgery, they got hooked on opiates, and then they turned to heroin or they're looking to turn to something else. What would you say is a legitimate alternative to uncouple yourself from an opiate?
Well, it's really hard once you're already on opioids because they do effectively decrease pain. But I think from here on out, they're going to start looking at doing non-pharmacological things first. So doing things like exercise, acupuncture, yoga, stretching, steroid injections, topical pain relievers, like nerve stimulators. They're going to have patients go to pain centers more instead of having primary care providers manage chronic pain, because these pain centers can you do urine drug screens to make sure that people are actually taking their medications and not selling it, which increases opioid misuse. They also can recommend other agents that are not opioids to help with pain. And when I went through pharmacy school, we always recommend a non-pharm treatment first. So if somebody has high blood pressure, the first thing we're going to do is we're not going to give them a medication. We're going to see, can you lose weight? Can you watch your diet? And come back in 6 months and we'll see if your blood pressure's down. If not, maybe it's hereditary, meaning it runs in your family. And so maybe you need to be on medication.
Do you personally feel like medical marijuana is a um, fair thing to explore, if legal in your state, to curb an addiction to opiates?
I'm a very study-based practitioner, and so I go a lot off of drug studies, and I don't feel comfortable recommending therapies if there's not studies to back them up, because that puts you at huge risk for malpractice suits, things like that. And I want to make sure what I recommend to patients is going to be safe for them. So currently, with how trials are, I would not recommend it.
Well, let's get into some weird questions here. We're going to go into a lightning question round. So,
Right.
you and I have had a chance to watch the TV show Hamilton's Pharmacopoeia,
Right.
which is a fascinating show, which is about a pharmacist and researcher who really goes really in depth to a lot of these illegal drugs that we hear about and shows how they're made and how they're used. And sometimes it's scary and sometimes it's not. But I think what could be an interesting part of this lightning round is I'm going to list out some illegal and some legal drugs. And if you're willing, would love to be able to have you answer what happens if I overdose on these, and see where that goes.
Can
Okay,
do.
you
I
ready
can
for
do.
the lightning round?
I am. I am just going to preface this by saying some of the illegal substances I am not that educated on because they don't teach those in pharmacy school, but I did look them up for the purposes of this podcast.
Well, that's
So,
fantastic. And I think we talked about beforehand, while you'll be mentioning some of these drugs and what happens when you overdose, or in some cases, you can't physically overdose from the volume that you take, that there's a lot of secondary things that can kill you, like a recent study that came out about marijuana, that while you can't OD on marijuana, There's plenty of people in Colorado that have walked across the street in the middle of a red light and got hit by a car.
Right.
So we're focusing in this lightning round on what actually happens if you take too much of the drug.
Correct.
Okay, so first drug, ecstasy, X, Molly, popular drug at
Right.
EDM concerts.
Right.
What's the effect if I take too much of that?
So they can cause life-threatening increases in your heart rate and your blood pressure. So if your blood pressure gets too high, then you're not going to get enough blood flow to your kidney or your liver. And so those can start shutting down. And you can also have what's called an aortic dissection if your blood pressure gets too high. So that's basically the vein that carries blood to the rest of your body, and that can like burst open.
What you're telling me is if I take too much X, I could literally explode the veins in my body,
Right. It's not as glamorous as Martin Lawrence on Bad Boys.
which is far more glamorous in this instance. Second one, LSD.
Right. So LSD, it used to be actually really popular back in the 70s. We don't see too much LSD coming into the hospital of like patients overdosing. And really, it's hard to actually overdose on LSD. It's usually people are dying from things that they do while on the medication. And also, if you take too much, what they call like super dosing, you can actually have changes to your brain chemistry. And so you start having behavioral changes to where you don't act the same as you did before.
That is overly scary. So not while you may not die, you could completely alter who you are as a person in a potentially not a good way.
Usually not a good way.
DMT. DMT is popularized for those that don't know, ayahuasca. There's a toad in Mexico that produces a poison that has DMT in it, acacia trees, stuff like that. So it's while not overly popular, it's becoming popular. So DMT.
Right. And I had never really even heard about this until we watched Hamilton's Pharmacopoeia. And so I did a little research into it. And most of the deaths that happened from DMT, the patients had pre existing conditions. So they already had heart problems, things like that. It can cause increase in heart rate, it can cause seizures. But a lot of people, like we saw in that video, they were performing one of these ceremonies and they were in water and they had to keep flipping the guy over or else he was going to drown. And so that's kind of where you see a lot of the deaths that happen from DMT.
Heroin.
So heroin actually converts into morphine in your body, and so it's going to have the same reaction as any opioid that would be if you overdosed on it. So you'll have respiratory depression. So basically, you stop breathing, altered mental status. So the person will look like they're out of it and not really responsive to you. A lot of times we try to sternal rub them. So it's where you take your knuckles and run them across your sternum to see if they arouse or wake up. And then it is life-threatening, so patients can die, especially if they combine it with things like alcohol, benzodiazepines like Ativan or Xanax. Those are benzos, and so if you put more than one respiratory depressant together, then you're going to have a higher risk of death.
Psilocybin, aka magic mushrooms.
Right. So this one, death from the drug itself is very rare. Some side effects would be GI upset a lot of times.
Another effect could be entering a fourth or fifth dimension that you didn't really want to go to.
Right. They also say like excessive sweating, excessive tear production, excessive salivating. So you're drooling a lot. And then you could have some kidney injury as well. But again, deaths from that are going to be more of what you do while you're on the drug.
Marijuana.
So this one, I'm going to preface with children actually can go into comas, and it can be really life-threatening for children. And so keep your edibles away from kids.
Lock up the edibles.
Lock up the edibles, especially because they look like candy, and what kid doesn't want to eat candy? But they can actually be, marijuana can be very detrimental to children. For adults, you're not really going to overdose on this. Typically, what they present to the emergency department for is either the behavioral changes, so they get a little too high and start freaking out, or if you use marijuana chronically, you can have what's called hyperemesis, and that's where you are vomiting and you can't stop. So it's like a lot of vomiting. And
That's scary.
Right, and they have cyclic vomiting syndrome, so every time you smoke marijuana, you just continuously vomit. And so I think that would turn maybe
We
some
may
people
need to
off.
change the name of this episode to Scared Straight with Lilian Caton, because I don't know if I would do any of these after this. Cocaine, blow, white girl.
So with this one, like the other stimulants, you can see an increase in heart rate and an increase in blood pressure. It can also cause arrhythmias. So that is an irregular heart rhythm, and those can be very dangerous sometimes. So your heart likes to beat in the right rhythm, and when it beats in a different rhythm, it can be deadly. Cocaine actually produces plaques in your arteries as well, and so it increases your thrombus risk. So that's a blood clot risk. And so blood clots can increase your risk of stroke. They can increase your risk of having a pulmonary embolism, which is a blood clot that goes to your lungs. And so patients that abuse cocaine a lot, their arteries look like they're 50 years older than what they really are.
That's scary. As Rick James would say, cocaine's a hell of a drug, and not a good way. Ketamine. I don't think most people know about ketamine. We saw this one in Hamilton's Pharmacopoeia. It's a drug that's used for anesthesia, correct?
Right.
And it is something that is being siphoned out of veterinary clinics.
Right.
Tell me about that and what happens when you OD.
So ketamine, we typically see in our hospital. They do use it, and really every practitioner is different. So there are some doctors that love using ketamine, other doctors don't like it as much. You'll find out in medicine that things come in waves. So, people new going through school, they learn about ketamine and they're like, oh, I love it. So basically, if someone comes in and they like have their hip dislocated, they'll give them a IV push. So a quick push of ketamine through their veins, and they'll pop their hip back in and the patient doesn't remember a thing. If you do overdose on it, which is rare to do inpatient, but outpatient, I'm sure you guys have probably seen on YouTube all those videos of like the naked men with like 8 times the strength. So psychosis is a huge side effect of ketamine. You also can see some respiratory depression as well. So you definitely can OD on ketamine.
You can lose your mind on ketamine.
Right.
Alcohol. I throw this one in here because I quit drinking 8 months ago. Well, a year ago. You quit drinking about 8 months ago. Mine for personal reasons, yours for health reasons. But I think it's an interesting thing that we don't ever talk about what happens when you drink too much.
Right. So unfortunately, we see a large population come into the hospital acutely intoxicated. And your body is just unable to break down all that alcohol at once. You're only able to break down a set amount of alcohol at one time. And so when you chronically drink, you really hurt your liver, and your liver is what cleans your blood. And so if you're not able to effectively clean your blood and you keep drinking, your liver keeps getting damage to it because you're putting all this pressure on it to try and break down all this alcohol you're ingesting. You also have an increased risk of GI bleeding, so stomach bleeds. You have the risk of forming ascites, which is a bunch of fluid on your belly, and that comes from the liver failure as well and makes it very uncomfortable for patients. You get high ammonia levels when you start getting end-stage liver failure.
How bad would you say alcohol is in comparison to all these other illegal ones we've listed out? Would you say they're equally as bad if abused, or where's alcohol compared to the list of
Oh, it
illegals?
100% is. You see so many detrimental side effects from patients that are abusing alcohol, and it is an addiction. And they, do require help and therapy a lot of times to stop drinking, but it is very detrimental to your health, and it's very sad to see these patients because they're always in the hospital and they just keep getting sicker and sicker, and it's a sad way to go for sure.
Let's discuss some ones that people may not think are drugs that can be abused. First one, ibuprofen.
Right. So that's in a class called NSAIDs, so non-steroidal anti-inflammatory drugs. So these you buy them over the counter, ibuprofen, naproxen, so Aleve, all in the same drug class. And if you overdose on these, you can have a higher risk of GI bleeding, so the stomach bleeds again, because ibuprofen is very hard on your stomach. It should really always be taken with food.
How do you know if you have a stomach bleed?
Check your poop. So if you have bright red blood in your stools, we call them, aka poop, then you probably have a lower GI bleed. If you have dark kind of tarry stools, then you have an upper GI bleed. And so that's why everyone really should be checking their poop.
And everybody poops, so it's
and
okay.
Everybody poops.
Excedrin.
So Excedrin has both, it depends on the formulation you get, but it usually has Tylenol, caffeine, and aspirin in it. So aspirin can be very detrimental if you take too much of it. Sometimes it even requires hemodialysis, so filtering out your blood to get rid of it. But it can cause tinnitus, which is ringing of your ears. So that's kind of the hallmark symptom. If somebody comes in with tinnitus, then we assume that they could have overdosed on aspirin. And then we kind of talked about Tylenol already. Wait, did we?
Yes, we talked about Tylenol earlier.
Yes. And then with caffeine, it's like if you drink too much coffee, right? Your heart rate increases, you get agitated, involuntary movements. So definitely don't want to overdose on Excedrin.
Let's talk cough syrup, aka Scissorp, Purple Drink, Lane.
Right. Popularized by
Lil Wayne
himself. So Scissorp, as I like to call it, is codeine with promethazine. So it is a prescription medication. You cannot get this over the counter. And it has codeine in it, which is an opioid. So you're still going to get the same reactions like if you were to overdose on heroin, respiratory depression, those side effects. With promethazine, that's an anti-nausea medication. And opioids make a great cough suppressant. So they stop your cough really well. But definitely that's not our first go-to. So if somebody has a cough, we're not like automatically going to give them Scissorp.
So with something like Purple Drink, we had a conversation about this the other day where you were like, I wish people would stop doing that because you run such a high risk of just dying.
Right.
Just dying, right? Like there's no warning, you're just dead, right? Is that common?
Yeah, so you hear the like horror stories in college of when they're like, oh, so and so got really drunk and died in his sleep or choked on his own vomit. That's because they were altered mental status and their respiratory depression. So alcohol also is a depressant on your system, and so it decreases your body's ability to breathe when you take too much of it. And so any of those, you're at a higher risk, especially if you're combining. And I'm pretty sure that when people misuse promethazine with codeine, that they are also probably drinking with it.
Nasal decongestants.
Right. So if you have any already pre-existing conditions of heart disease of any kind, you really need to talk to your doctor before you even start a nasal decongestant because it can raise your blood pressure. It can raise your heart rate. It can cause arrhythmias, so those irregular heart rhythms that we talked about earlier. And so definitely don't want to OD on those. And a lot of those you do have to get behind the counter. And, it's annoying because you have to have your ID and you have to sign a thing saying you're not going to make meth with it. But we've had to start doing that because the meth population or the meth production from nasal decongestants are crazy.
Got two more on this list.
Right.
Pepto-Bismol.
Right. So this one, I'm just going to put this disclaimer out there to begin with. Pepto-Bismol can make your tongue and your stools black. So if you see that and you're taking it as prescribed, do not be alarmed because that is just a side effect of the medication. You're going to be really constipated. And if you take a lot of Pepto-Bismol, you can have the same side effects as if you took too much aspirin because they are kind of in the same family.
Last one, Viagra.
So I would not recommend overdosing on Viagra. So it's going to drop your blood pressure really low, which puts you at risk for passing out. And it also can cause priapism, which is a prolonged boner, or I guess I should be a little more clinical and say erection.
But is that a bad thing?
Well, it is if you have to get a needle stuck in your penis to get it to go down.
Okay, yes. That is a bad thing.
I would not recommend overdosing on Viagra.
So you could overdose on Viagra and it could not go away, and the only way to get it to go away is a needle in it. Is that correct? Mm-hmm. Yeah,
yes.
I'm not going to recommend anybody to OD on Viagra. At least please remember how many that you've taken. What's the weirdest thing that you've seen somebody OD on?
Probably the weirdest thing I've seen them OD on, and then I'll talk about the weirdest way I've seen them OD. So the weirdest thing is we had a patient that was crushing up her Ambien, which is a sleep aid. It's a controlled substance, and she was injecting it. And patients shouldn't, you don't inject things into your veins because that puts you at high risk of bloodstream infections, heart valve infections, death. And so basically anybody that tries to like crush something up and inject it, just don't. The weirdest way I've seen somebody OD was I had a patient that had burn marks all over his body, and come to find out he had stuck a bunch of fentanyl patches all over his body, put heating pads on them because he wanted them to absorb faster. So fentanyl is an opioid. And so he was non-responsive, had to have a breathing tube put in, and I watched him pull that breathing tube out and his urinary catheter all at once, blood spewing everywhere, because he finally came to because the fentanyl wore off. So
That's insane.
right.
There's a natural curiosity in mankind to try drugs, expand the mind, peer pressure, all these different things. What would you recommend to everyone out there that is looking to experiment with an illegal drug?
Don't do it.
Could you elaborate? Because the don't do drugs campaign almost breeds more curiosity. So
Right.
elaborate for me.
So I think I'm going to talk from a prescription drug point. I think everybody needs to be educated. So if you don't feel like you're educated, or you feel like you're not getting the answers you need to seek the answers that you need. You need to be able to have the information so that you can best manage your health and to be aware of what you're putting in your body. You know, one of the things I hate the most is when a patient is like, "Oh, yeah, I'm on that, but I don't know what it's for." Like, I want all of my patients to know what all their medications are for. I want them to care enough to know. Now, granted, that's probably never going to happen, but I love it when a patient is like, "Oh, yeah, I take this medication at this time and it's for this." I know that somebody out there was doing their job that day and that the patient cares about themselves, and those patients have the better, they live longer, they live better, they have a better quality of life. And so it just makes me feel like my job is all worth something when I get to help patients like that.
So a big part of it's education. Would you say the same thing? So you said that about prescription drugs. Would you say the same thing about recreational? Don't do it, but if someone's really going to do it, do you think they should educate themselves on it?
I do. Because same thing, like dosing of illegal drugs. You might not know what it is that's in it, and it could have different potencies depending on who makes it. But you need to be aware of how much you're using. So don't go out there and take like 15 edibles the first time because you're going to freak out. And so I think educating yourself if you're going to do it, and there's plenty of things on the internet that I will let you know the DEA is watching all of the message boards out there. So be careful what you post if you are posting things. But there's plenty of information that you can get on the internet nowadays compared to like when our parents were experimenting with drugs in the 70s. But education is a huge thing, I think, if you're going to be using any sort of drug.
A wise man once told me if you're going to do something very stupid, counteract it with something very smart. So that sounds like the very smart thing is to educate yourself and understand what a lot of these drugs are made from. And I don't think most people know that, you can go get an ecstasy pill and you don't know where that was made. It could have been made
Right.
in the Netherlands in a great clean facility, but it could also have been a homebrew job out of San Francisco, and it could have been cut with something that, really is destructive to your body. So
Right.
education sounds like a pretty good piece of advice. Do you believe in the future of pharmaceutical technology advancements? It just feels like, we haven't seen I don't feel like we've seen a new drug, game-changing drug. Well, why? Do you believe in the future of it? Tell me a little bit about that.
So I do, because medical field is always changing. So we're now starting to see bacteria that used to be susceptible, so antibiotics used to cure it, and now it's becoming resistant to a lot of antibiotics that we have. And that's a whole other topic that you could do a whole explain it like I'm five on antibiotic resistance. but they're starting to come out with new antibiotics, and we haven't had to have new antibiotics for years, but now they're seeing the need for them. And so we have drug companies that are producing new antibiotics that we can use for these patients that nothing else can treat them. I mean, how terrible one day if we all die of like super gonorrhea because none of our antibiotics work. So we have to keep making new things to help treat. And as far as technology goes, that's just going to keep getting better and better. You know, we have a huge robot that we don't have to have a technician go and pull every single tablet for every single patient and have a pharmacist check every single thing. We have a pharmacist check the medications that go into the robot, and then the robot does its thing. And we just got a new IV robot as well, and that makes IV medications for us so that we don't have to we can use our manpower to do other things.
Do you feel like we're ever going to see another Sir Alexander Fleming, somebody that makes a drug like an antibiotic, penicillin, and then gives it away to the world for free? Or do you feel like the world's just become so, I mean, maybe that's not bad, but it's just become so commercial and so lucrative. Like, why would you give it away from free?
Yeah, I don't think that's ever going to happen. Not that I don't think people would want that to happen, but with the pharmaceutical companies, every little company gets bought out by somebody else, and every big company gets bought out by another big company. And there's just so many mergers happening, and all these compounds that pharmaceutical companies own the rights to. And I just, we can't just have like Joe Schmo cooking up a new pill up in his backyard, and then a pharmacy is going to buy that and start distributing that. That's not how the regulation works. And so you have to go through the appropriate channels. And so I don't think we're going to see something like that.
To wrap this up, it's one last question I have for you. You seem like a smart, neutral, responsible adult. What would you tell the potential millions of people that will view this video or listen to this podcast? What's the one thing you want them to walk away? Something small that if even some of this was overwhelming from them, what's the one takeaway?
I think just educate yourselves. If you feel like wherever you fill your medications or whoever you go see for your doctor isn't spending the time to help you understand what's wrong with you or help you understand why you're on a medication or what happens when you're on a medication, then maybe you need to go to somebody different. I want all my patients to feel comfortable with the medications that they're on, and I don't want them to have questions when they go home. Or if they do have questions when they go home, I tell them hospitals open all the time. Give us a call anytime you need, because I want them to have somebody that is always going to be there for them, because I went through 6 years of this and I still don't know everything. So imagine somebody who didn't go through any schooling for it and how lost they must feel when they have to start taking medications.
I think the first reaction from what you just said is people are going to go hop online and type into Google, what they're interested in. Is WebMD a valid resource for educating some yourself?
So there are tons of good online resources. I would not choose WebMD though. You really have to look at resources that, and we honestly had a whole class about this in pharmacy school, but resources that are really good and have good clinical information and have good resources that they use. Because you're not going to go online and like look at a drug trial. You're going to go online and look at an article that is summarizing a drug trial. And so unless you're going to go out there and read the drug trials yourself and evaluate those, you really need to make sure you're looking at good resources. And any pharmacist or doctor can tell you what resources to look at online.
Well, Lilian, I appreciate you coming on the show. I appreciate the support both on the show and off the show. And I hope that the listeners felt that this was both educational and enlightening. So thank you very much. Thank you for being on the show.
Thank you for having me.
Can you just explain it like I'm 5?